Is that better?
Yeah, what are you saying?
Yes.
Okay.
Yep, go for it, go for it.
So I'm Clare and this is Cheryl, my colleague. I used to work in the inpatient service and now moved took quite retirement and gone to the outpatient service. So Cheryl's the lead nurse for the inpatient service now. So I've been asked to come and talk to you a little bit about sort of people coming into hospital and issues that people have with diabetes when they come into hospital, and also about people that are coming into surgery when they come to surgery. So one of the things that I run now is we call the pre-op clinic. So we've set up somewhere with the anaesthetists to look at patients that are coming into surgery that have got diabetes, because we know that some reports out there that have said that people don't do very well if they have diabetes, or can sometimes not do well if their blood sugars aren't controlled. It usually leads to an increased length of stay in hospital, and you can have problems with breathing and things after. So it's really, really important that we do try and get good control for people that are having diabetes. But I think just asking out to the group, what kind of worries you about having surgery, about when you have to have surgery, have you had any surgery that you sort of had experience of coming into hospital and had problems while you were there or before you came, you know, anything? Yeah,
I broke my leg, that's about broke my ankle,
okay.
and I was panicking when I came round. But where's my meter? And they said that when we say you can have your meter, you can have your meter. But looking back on it, they were right, because as they said, I didn't really come out of the anaesthetic.
Yeah.
So, but they did let me have my meter. But the thing that got me, they were coming around to, we want to test your blood glucose.
Yeah.
They said, there's no good doing it at 10 o'clock. I need to, and they didn't seem to, I mean, things since this 4 years ago,
Yeah.
it probably changed. But they didn't seem to realise why I wanted to take my blood glucose before my meal,
Yeah.
as well as at 10 o'clock.
Yeah. And I think it is a big concern, and it's difficult. I'm not defending the nurses, but obviously if you've got a ward, so one in 5 patients in hospital will have diabetes, so 20% of people in hospital have diabetes at any one time. If you've got a ward with 10, 15 people on with diabetes, to try and get everyone to get the blood sugar done before a meal is not always possible. It's ideal that what we do strive for is what we do try and encourage people. And I know we're doing a lot more work around self-administration and people being able to have their own meters. However, on the flip side of that, from a trust point of view, we have to have an audit trail for anybody that has a blood sugar done. So if we're basing a decision on it, it has to be audited. So we have to use that meter for.
I was going to say, you think about it in retrospect, they probably wanted me to test my blood for different reasons, what I wanted to test it from anyway. So they were looking at different results.
So I think we probably tend to encourage that you can test your own on your own meter, but we have to have a certain level of blood test done on our machine every 24 hours.
Yeah.
So it's an audit trail. That's what we have to work on. Any other concerns that people have got when through the surgery? Usually it's about actually losing control and everything being took off you when you come through that hospital door. Yeah.
Mine was had to have an endoscopy, and it meant to eat like foods with like no fibre in for a few days, and then I think start fasting at some point. And had loads of hypos. So I did have to eat. And I explained when I got there, you know, this has happened, and obviously, and I wasn't going unconscious, but so the doctor says, "We'll do you first." But then while she was doing it, she kept going, so it's a little camera up your bum, and she kept saying, "Oh, it's so dirty, it's so dirty." And, it was just that I should have used a different word, like there was a little bit of debris in the way here or something.
It's difficult, I think, for fasting procedures, but I mean, obviously, some type 1 would tend to try and say that if your background insulin's right, you should be able to fast and not have to cause any sort of problems with your blood sugars. So if somebody with type 2 diabetes on the mix or something, again, that can be quite difficult to manage. But we're always available. So we do have what we call a diabetes gateway that's available Monday to Friday. So there are some guidance out there for you to come in for procedure, what to do with your insulin and with diet and things. But if you are concerned or you feel as though the advice should not been given, just give us a ring and we'll go through what might work for you. Because obviously you're all aware with diabetes, what works for one person doesn't always work for somebody else. So it's about sort of personalising it to you if there's any information.
It's the case with the general anaesthetic. How far in advance do you need not to be eating and drinking?
Oh, I think it depends on the surgery. I think it depends on what surgery you're having. It's usually at least 4 hours. I know it's not as long as it used to be. We used to start people from the day before, so I know things are better. It's at least 4 to 6 hours before the surgery.
No, it's not midnight, but it can, the surgery, you can have sometimes 3 hours before.
Yeah, I've had 3 different sets of information,
Yeah.
something that I'm having in a week's time. So
All right, okay. So not good if you've been told different things, but have you been through like central pre-op?
pre-op said one thing,
Yeah,
which was not that far away from what I had from the nurse from Hampshire.
yeah.
But the letter said I could eat and drink as normal on the day of admission.
All right, okay. That's a big thing. I would probably go with what the pre-op said, but they're probably the ones that were when the surgery's going.
Well, I know exactly when it is.
Yeah.
Because I'm going to, I've got to be there for 7 in the morning.
Right, okay, yeah.
First up, apparently.
All right, okay.
Yeah.
There's nothing else in that one.
Next slide.
Okay.
Does anyone on your hand have a comment?
So this is just really think a little bit about something that's coming in. Obviously for elective surgery, it's very different. We know that you're going to be coming in and we can train the plans for you. You will usually attend through to central pre-op clinic, but some of the surgical teams in Sheffield don't come through central pre-op. So cardiac surgery is a different pre-op. And some of the ophthalmology surgeries are different pre-op. They don't actually come through central pre-op. So the work we're doing at the minute is only with people that come through central pre-op.
Excuse me, sorry to interrupt, but the online ones, we can't see the slides. We're still on number 1.
Huh?
Yes.
Right. I'll just go backwards and forwards.
Sorry, is the central pre-op the one just down
It's
the
on
road?
Mulberry Street, yeah, the one on Mulberry Street. So it's moved from the hospital to Mulberry Street.
How's that? Has it changed?
No, it hasn't, David. I was just about to raise the same thing before Shirley. We're still on the patient group presentation, Cheryl and Claire.
Okay. We're just going to stop share and start again.
We're okay now. I've got that one.
Okay. Can you see a change in slides?
Yes.
Claire's trying to get in. Could I be host?
Could do. Have you seen a change in slides?
Yeah.
Yep. What slide are we on now?
Elective emergency.
All right. This is slide 3.
Yeah.
So yeah, so we're wanting to aim for good control, but for the pre-op clinic, it's probably not as controlled to what you're probably used to knowing about. So for surgery to get the HbA1c needs to be less than 69, which probably seems quite relaxed for what some of you are striving for, but that's the number that we've been given. It needs to be less than 70, so we're to 69. So if the HbA1c is above that number, when you come through to central pre-op, you will be referred into the diabetes centres to try and support you to optimise your control. If it's urgent surgery or cancer pathway, your surgery may well be in a couple of weeks, but we can still try and support for a couple of weeks before that surgery goes ahead. So we will still try and optimise it in that time. And the pre-op clinic have done a lot of work with us as well, and we've gone through which insulins to stock and when which to reduce, how much to reduce by. So the elective progress has not been much smoother, you know, you can be prepared for it. Obviously, with an emergency, it's very different. You're brought into A&E or, you know, you come in for urgent surgery, and it's very different. You're in a bit of a turmoil, you just grab what you need to cover. So what I would really say is really important is to try and bring in the medication, because it's easy to get the wrong insulin, you know, prescribed. So we want to make sure that you're as safe as possible. If you can bring your insulin, bring your insulin pens, and if somebody does know your doses, that helps a lot as well.
And sometimes medication's quite okay to take around. Is a prescription is good?
Yeah, if you've got your prescription as well, it's keeping it in the thing is, yeah, it's probably the doses is probably, for somebody with diabetes, we often, you know, we'll get a call on the ward that says this patient's been admitted, what are the doses? And the last dose we can see was probably when somebody was 6 months ago, and you may well have altered yourselves in that meantime, so we should only go on what information we've got. So if you've got your up-to-date doses, that's really useful.
So for insulin, it wouldn't tell you anyway, would it?
No, that's what I'm saying. So if you maybe if there's somewhere of you,
Write it down.
or
That's good
somebody
idea,
that you know, just
yeah.
run through what your latest doses are.
Doses and insulin are really difficult in hospital, but nobody knows what anybody's on.
So it's quite a good idea to keep an old
Yeah.
very old prescription, you know, and just write down on it how much background and so
Yeah.
and
Yeah, that's
more
really
than
useful.
needed, yeah. Because you're not going to know the daytime, but
Yeah.
or just the ratio as well. That would be quite
Yeah,
useful.
that's right. So for us, not for the hospital.
My dose is different every day depending on the reading, so.
Yeah. So I think if your background was roughly about the same,
Yeah,
then you
I
could
just
say
have
you'll
the-
have
I just have the
variable
one
dose.
insulin every day, but
Yeah, so I think as long as you've got a rough idea that it's not, but what I will say is we have got a safety net in place that if somebody's not able to tell us what their dose is, we actually just give a dose of Levemir, just to avoid the risk of decay or sugar getting too high, and so the diabetes nurses can try and investigate and find out what the normal dose is.
Yeah, a lot of the hours we've got the river, you know, we've got the
Yeah.
Can people not?
The ward staff don't have access to that, only the diabetes staff have access to that. Yeah, the ward staff don't have access to that.
Somehow get that.
No,
It's all there.
yeah, they would have access to that. It would only be the diabetes centre, but within that, if you're admitted overnight, there's diabetes needs on 7 days a week. So there's some of them that they'll be review the next morning. So the longest potentially you're going to be without your regular dose of insulin is 12 overnight. And then obviously for your surgery as well is if you've had emergency surgery, to try and improve the control after you've had your surgery to keep you, you know, to reduce the risk of problems post-op.
Got some chat comments. One was around, this was around pumps and CGM, so partly what Carol said, but also CGMs. People are, sorry, people are connected to a pump, aren't they? So what do you do? Do you disconnect people from the pumps or just keep them going?
To manage it themselves, we would encourage them to keep. Same will apply with the CGM. It's not a blood glucose monitoring within Sheffield Teaching Hospitals. So we do have to check at least 2 blood sugars in 20.
Okay.
CGM or you do. If you're unable to manage the pump, confused, something happens in hospital, we would take it off, change it with the battery. Variable, sensitive. It would be just for the diabetes.
Yes, thank you.
You go to the next slide. Is that right?
Slide. Just got another query, was how is diabetes pre-op accessed?
So the referral comes through from the central pre-op clinic. So if you've attended central pre-op clinic, you'll have your HbA1c checked. If support take or 69 will be referred into a certain range the year. That lasts 16 weeks. So we've got 16-week window to get your referral optimised during that time. And we usually succeed pretty much most of the time with it. We're doing really well with it. Because people are obviously keen to get the surgery done, so they're keen to get things improved during that time. We have also got referrals through from the orthopedic foot clinics, and we've had odd referrals from other places as well that you've really service. So just looking at why we want your blood sugar good, we know that if you've got good glucose control, it improves your wound healing, it reduces your risk of infection, reduces your risk during surgery, not having hypos or your blood sugar not really high during your surgery, and potentially reduces your length of stay. So length of stay tends to be sort of 3 to 4 days longer in people with diabetes than it is with people without. Obviously, then you've got better outcomes post surgery, but I think also when we're optimising people's control, it's not just for the surgery, it's actually for the longer term health condition as well, and long term support that we are trying to increase. You know, patients that come through pre-op with a HbA1c of 120 odd, if we could get that down and then get down to surgery. We're doing some work at the moment where we're checking HbA1c at 3, 6 and 12 months post surgery, and we are still maintaining some of those improved HbA1c, which is really good.
Next slide up.
This side, talking process. So at the moment, you attend your GP and you get referred up to the surgeon, who then decides whether you can have your surgery or not. We're hoping to try and move this process back a little bit. So actually, when you go to GP, they optimise your control before they refer you for surgery. So HbA1c is 120, we shouldn't really be referring you for surgery anyway, we should be trying to get things better at that point. So we are trying to move it back a little bit further. But at the moment, you've seen a surgeon, they've agreed that you can have a surgery and they'll refer you through to the pre-op clinic. Once you come through pre-op, like I say, if it's raised, they'll refer you through to us. We've got that 16-week window. And like I say, it can be done. We can get those blood sugars down. Even with the cancer pathway where we've got 2 weeks, we can still try and improve people's control in those 2 weeks. So we might not be getting, well, we're not going to check the HbA1c again in that time, but we can see that blood sugars have come down in single figures. So that's really good in time. We contact you, make an appointment, usually face-to-face if you can try and get it. We've got clinics at the Hallamshire and at the Northern. We're quite aggressive with the titration. It's usually sort of every week and getting you to do things in between as well, just try and get things improved as much as we can. Look around your lifestyle, look around diet, and we're also asking people to come in for a monthly HbA1c checks and a meter download. So we can see and you can actually see that what we're doing is making a difference. And it's been agreed with the surgeons and the pre-op team that although your HbA1c might not come down to 69, if your blood sugars are all in single figures and your HbA1c is on the way down with a surgery to go ahead at that point, by the time you get your date for surgery, your HbA1c will have brought up. So then we'd refer you back for surgery. So we have no control over surgery date, unfortunately. As much as we would like to, we don't have any control over that.
You can't have a get out of jail free card or anything. No.
So as soon as we get it, we send an email that said go ahead, we're happy, and then they'll let you date research. Okay, any questions on that?
The short term part of things.
Yeah.
Because I had the pre-op last Wednesday.
Yeah.
And I had a phone call, I think it was about Tuesday this week, saying it was Hallamshire referred to Northern General. Northern General rang, and the appointment for a diabetic nurse is going to be about a week after the operation.
Right. Okay. So if it's an urgent pathway, what we'd usually do if we've been asked is try and overbook our clinic. Our clinic waiting time. The first appointment we've got at the minute is the 2nd of December, but we will try and overbook a clinic. So we will be trying to sort of book you into an early for a telephone slot if we can. I'm not sure if why that's not being done. If I should have been done.
Right, thanks. No, it's just
yeah. No, the first telephone slot and first face is the 2nd and 7th of December that we've got at the moment. So anything before then we'd have to open the clinic. So but we do try and do that if we can.
Can I ask, are you teaching the managers who arrange these operations that you're talking about at the moment?
No.
Some around here may not know that I spent 50 years in the NHS and surgery. I now understand that managers will tell surgeons when they're going to do an operation. We never had that at the Children's Hospital in all the 30 years I was there. We didn't need it. If they don't understand what's being said about diabetes, they won't get the dates and the appointments right.
Yeah.
So
I think
should they all be sitting here listening to you tonight?
probably yes, I think they should be. I think we've made a lot of inroads with the needs tests. I think that's really massive inroad to actually for them to acknowledge that they need to get people's control. There's been a lot of work done, Alexa and Dennis.
Are are these the managers?
They're the
clinicians might, sure.
Yeah, central pre-op leads that have worked with the systems and we've done a lot of information saying you can't go ahead with this surgery unless control is good, and then they bounce it back to the surgeons and say unless you get the control we don't do the surgery. So I think probably the needs to lead a bit more than the surgery.
Well, I think that's right, but
Yeah, the powers
I want the manager who's deciding when somebody's going to have an operation done to know what they're talking about.
We need to be back into them and try and work with it. I think certainly because of the pre-op clinic now, they don't get that back to the waiting list team until the control is better. So they shouldn't be then going ahead with surgery.
I hope that the rest of the audience understand what you're saying and believe it.
From experience from doing this work, and we started this about a year ago, we've got about 360 patients through. We are not getting patients. There seems to be more day surgery getting done, which is great. People with diabetes and things coming the day before, which is what used to happen, which is really good.
So you get more what?
So more day surgery, so patients
Oh,
coming on the day
yeah.
for the surgery rather than having to get admitted the night before, which is really good. And the surgeons are actually, we've had a few of these tests that have actually said we are not doing that surgery until that control is better. So I think that is getting better. There's been a lot of work done nationally, and I'm hoping that we're getting on board with that and remove the use for the issue.
When somebody's going for an op, and they say get your weight down, if they're diabetic, does the blood glucose HbA1c make more difference than the weight, or is it?
This is the argument we've had about the diabetes patients, because they might be told to improve the blood pressure, they might be told to stop smoking, but in the past they've just gone ahead regardless of what the diabetes control was like, and that's where a lot of this work has come from. But it's actually you've got to look at everything, you've got to look at blood pressure, the weight, and the smoking status.
And the other thing is when you say you try and get the control down, do you give them the meters and such, right, even if they haven't got the strips? Yes.
So when you actually get referred, when we first triage the referral, if you're not monitoring, we'll send you a meter out, and actually start monitoring before you come to your appointment or before you leave here. Start whichever treatment we need to. We're getting a lot of people from out of the area, so sometimes it's contacting the local diabetes team and asking them to initiate the treatment rather than bringing somebody from Leeds into Sheffield for an appointment. They'll contact the local team or just but you will still make contact. So they're sent a meter out with strips. There's a YouTube video and it starts to use the meter, so that's all ready. So even if it's on metformin, you'll just get them out monitoring. So it writes the GP and say they've started this monitoring, you need to prescribe the strip. But I know that isn't an issue, is it? They're not going to be as able to, so they'll all get the strips when they need.
So if you're already monitoring to a certain extent, like twice a day, and you're asked to do it 3 times a day, is that fed from the hospital to the GP as well?
It is, yeah. So we'd ask you to test 4 times a day, so before each meal and before bed, for 7 days before you come for your appointment, so we can actually see what the blood sugars are and where we start to treat things. So we contact you and say we need to give them more strips. Yeah.
Right, that makes sense.
Question from the chat is, what does aggressive titration mean?
It seems to me.
That's probably just a way to use. Well, a lot of the diabetes nurse points, a lot of community points, and some of the points may be 4, 5, 6 weeks apart. So you might be given a plan and then you ring 4 weeks later, re-increase again if the patient's not done it. Whereas we will actually ring every week for over 2 weeks, trying to do things that really trying to get done straight quickly. Okay, is that a good question? Yeah.
I asked a question, but I couldn't hear the answer.
Oh, hang on. What was that? You want the answer repeating again?
Yes, please.
So sorry, I was saying, like, for some of the patients who've got like community nurse appointments or an SGH GSN appointment, they might only be getting appointments every 4 weeks or 6 weeks or even longer than that at the moment. So part of the pre-op clinic is we can actually bring every week or every 2 weeks as we need to, so we can really support people. Not everybody's confident, obviously. Some people are really confident and happy to titrate in between, but other people aren't. So we can bring every week to really increase things, which was very quickly.
So what does titrate mean then? I did chemistry and
Okay, so sorry,
it has nothing to do with what you're talking about.
So it just means looking at your blood sugars and supporting the dose titration with dose increases, whether it be insulin or the GLP-1 injections. It's just constantly upping the doses really to get the blood sugars under control.
Right.
Yeah.
Does it kind of like management, kind of titration management? Just wondering.
Is what, sorry?
Could you use management as
Yeah, we could
instead
use-
of titration?
Titrate doses, that's how we
Yeah,
yeah.
which is what we do every day, but yeah,
So it's not-
we don't call it. Yeah. So, well, I might start using it. Got some questions that people have sent in, which I forgot to send to you. I'm sorry. Just thinking. One I could read out. One's really relevant now, and then one's about discharge. Oh yeah, 2 are about discharge and one's about going in.
Yeah.
Okay. You probably could move on to the next thing. I might take a minute to find it. Sorry.
I move to slide 6.
So this is sort of obviously on your day of surgery, the central pre-op clinic will have advised you on what to do with your medication, what to do with your insulin. On the day of surgery and even the day before surgery, we recommend reducing doses the day before surgery for some people. If you're on an SGLT2I, so that's one of the new empagliflozins or dapagliflozins, that's got to be stopped 48 hours pre-op, because there is a risk of developing diabetic ketoacidosis if that's continued or anything like that. And it's in the female. Fasting check. So usually we'll look at what somebody's blood sugars are, and depending on how long the surgery is, how long it is willing to be eating and drinking again, we just monitor blood sugars. We don't start an intravenous insulin infusion. It's only like maybe you're having a line and not getting till 11 o'clock as opposed to usually being insulin 8 o'clock or something like that. So we'll just watch and see what happens. But if the blood sugars rise above 12 on 2 consecutive occasions, then our guidance is that we have an intravenous insulin infusion started. Once we've got to that level. It may be slightly different if you're attending just day case surgery. Like I say, if you attend day case surgery and the blood sugar is elevated, they will give you PRA to bring your blood sugar down. Wait a couple of hours. If it's in target, then the surgery can go ahead. So there is guidance there now to give. We used to get a lot of patients that were turned away on the day because it's not the medication the day before, as they've been told to be turned with a blood sugar of 20, say, who did cancel the surgery on the day. So now we've got a plan in place to give insulin to stop that happening. Background insulin is always continued whilst you're on an IV insulin infusion. That will depend on whether you've got type 1 or type 2 diabetes, whether it's your normal dose or a reduced dose. And usually if you've been put on intravenous insulin infusion for more than 24 hours, you will be referred to the diabetes inpatient team, or if there's any other issues, any hypos or high blood sugars or anything. And at that point, if you feel that you want to ask for referral, just ask them to refer. We do accept health referrals as well.
What does LOS mean?
Length of stay.
Length of stay.
Yeah, sorry,
right.
the shocking abbreviation.
Yeah.
Depends how long you're in for and how long it is the thing you can drink next time.
Okay. This question goes back a bit, somebody's experience while they're having day surgery. So there seemed to be a lack of communication in hospital. I had day surgery and was nil by mouth and kept being bumped down the list and then off the list 3 times in the same week and sent home. I asked for a diabetes nurse, but they had no idea who to contact. I was literally next door to the diabetes centre at the Hallamshire, but nobody would advocate for me. So it was somebody having jaw surgery, which might mean they didn't, that's why they didn't know about it, I don't know. But anyway, when they did find a nurse, they weren't able to attend pre or post surgery. Surgery was on jaw and posed eating difficulties. What should have happened and what can be put in place? My anaesthetist told me, wait for this, he would increase insulin if I went hypo, which was rather frightening when you're under a general anaesthetic and vulnerable. What did you say to me? Oh,
Thank you. You get in contact with this. Yeah, but I'm not sure if it's the same patient. It sounds really very similar.
Yeah.
I mean, we should, obviously, if, was it recent, was it within?
It says it was during COVID, so the partner wasn't able to be there or to speak up for them.
So I think, yeah, I mean, the pre-op's only been set up since COVID, where we've been doing diabetes. COVID was extremely difficult for us. We had seen patients in the route to the wards.
Yeah.
So we were actually left with one DSO on each side. So we had one inpatient nurse within the whole of them, one patient nurse within the Hampshire. So we had to prioritise what we could do at that point. And often it led to a lot of remote reviews. So we may not have actually physically gone up to the ward, but we were doing remote reviews and advising the wards or the areas. And we cannot see it with the best one in the world. We would love to see everybody that comes into hospital with diabetes, but we just cannot do that. So we have to have new shelves and sort of stuff to make criteria later. Idea, I mean, I would say said she could have, but he or she could have asked them to the diabetes centre and see if
Sounds like they did.
Yeah. I mean, it sounds like I don't know if they didn't actually physically come and see the patient, but it may be that they did give advice either over phone.
Difficult to know why they cancel it as well, because that's out of our hands. So
Yeah.
if it's coming in, they cancel it. Is an emergency. It's difficult, and depending on what information was relayed back to us would be dependent on what we did. So if it was cancelled and that's it, there would be nothing we could really do.
Yeah.
But if they were wanting to have surgery, then we would have given them to.
The thing is, that's
if saying was essentially they needed a fee, they should have been fee.
But when you say a feed, what's that?
So if they had to have a nasogastric boost, if you said it was jaw surgery, we weren't able to eat.
Yeah.
But they should essentially do to us. It would, I mean, obviously they were having a responsibility.
Yeah.
And if somebody's safely still alone due to surgery, if you gave them intravenous glucose, would they still get to the surgery? I mean, does it not affect with the? I mean, when you say newborn now, is that to do with the digestive system?
If they had that, if they had had glucose surgery, would still be able to go ahead.
You could still start intravenous. Yeah, you could bring it up. So
so the intravenous insulin infusion surgery is glucose and insulin, which go in constantly.
Yeah,
and we adjust that to the things that how much.
And the other thing I was going to ask is,
the blood sugar is.
When this person said, and other people have said, oh, they put me back in the list, I'm wondering whether this was because they were diabetic and the blood glucose wasn't right, but nobody bothered to tell them that was the reason. Do you think that they do get feedback as to that's why? Or-
Potentially, I mean, I've been around some time in nursing, and the patients with diabetes were always done first on the list because it was thought that was the
Yes, so
best thing
that's
to do,
what I mean.
first on the
Well, I
list.
broke my ankle.
However, actually, I think some, yeah.
That's what they did next morning. And I said, come
on,
on, you're going first.
Yeah.
And there's one or two people who said, how come you're getting in person? Well, there's got to be some advantages.
yeah. But
But
I
I
think
just wondered whether
sometimes
get feedback. They're told that that's why, you know, with the.
not. I don't know. But I think sometimes now we tend to avoid doing first on the list and actually get control stable before we take them to theatre now, so they don't always go first on the list.
Yeah, but what I'm thinking is if you give people feedback more generally, not about themselves, but about other people, that if your blood glucose isn't right, you're going to get delayed. It would be a good incentive to people to try even harder to get the blood glucose right when they're going in for an op.
During COVID as well, it was very difficult throughout the whole hospital, so everything went kaput immediately. It was really difficult. So yeah, staffing levels and
I think also now COVID was dexamethasone, which was, you know, brilliant for COVID, but dexamethasone was diabetes team caseload just shot up through the roof.
Yeah.
People without diabetes developing, you know, steroid-induced diabetes, people with diabetes having COVID, then having dexamethasone on top of that. That was really challenging times actually for a while.
So did you say that COVID induced diabetes?
So no, so when they start to treat COVID patients with dexamethasone, that causes diabetes, can cause diabetes.
It's a steroid.
It's a steroid, so it can cause diabetes or it can worsen somebody's diabetes. So obviously then everybody ended up with dexamethasone that was on oxygen for the COVID. Our caseload just.
and it also highlighted a lot of patients didn't know that they had diabetes. They came into hospital, would ask for the HbA1c to be done because they were going to put them on steroids, and sometimes they were 86 and the patient didn't even know that they got diabetes. So it highlighted a lot of patients that already.
So would that be temporary or permanent diabetes?
With steroids, it depends. Sometimes it resolves as the steroids reduce. For some people it doesn't. So it's a bit of a, and you can't predict how people are going to work with the steroids as well. And that will affect everything.
So going back to the, you know, going for an operation, you're saying if you're high, you'll try and bring it down. 12 is your sort of cut-off. But if you're, was I understanding that if you're sort of going towards the low end of things, then some glucose is given to you to bring you into the range? Is that what happens?
You were treated with IV glucose, you're nil by mouth, and treat the hypo.
If you know by mouth, generally put a kind of room.
No, I'm just thinking sort of what's, you know, obviously you want to try and get it to go, but you want to be not too low, but there are ways if you're low that they can sort of sort it, whereas if you're high, it's harder to get sorted. That they sort of.
I mean, obviously with the lows, you just want to get it up as quick as you can. We don't want to be low, but sometimes we want to get it up. But with the highs, once it is above 12, we will put that intravenous insulin infusion up. So you've got, like I said, insulin and glucose going in at the sides at the same time. Measure the blood sugar every hour, and depending on what that blood sugar is, you will alter the insulin infusion and to keep the blood sugars in a set range of 12.
Sliding scale.
Yeah, sliding. Yeah. We have to call it variable rate insulin infusion now. I'm trying to get away from using the sliding scale, but it's an old, you know, it's what we, we still call it sliding scale to be all right.
So if you're aiming to be at least under 10 when you start fasting, that should be okay until you sort of get operated. If it's 6 hours later,
Yeah.
is that the sort of?
You can get a bit of a stress response as well. So
Oh, right.
you can make your blood sugars a little bit higher. So they check them throughout surgery as well. And the same rule applies.
So just before I'm up, is it easier? I don't know if this is what I'm thinking about, but is it easier for you if the patient is going too low because the glucose will act quicker? Whereas if they're too high, you've got to wait at least 2 hours before the insulin going to work effectively. So does it make any difference, or would you think it won't?
No.
That high or, I mean, we have some people, don't we, if it's 20, which we do, for the day case, they will give this. They may delay the timing of which you go. So they like to optimize you to get rid of sugars and target price, for all those reasons that I mentioned earlier.
So that would
They might delay.
take a lot longer to bring the
surgery.
blood glucose down
Yeah.
than it would if somebody just goes hypo and just put it up the blue.
If you're on a
It's
sliding
IV,
scale,
it's IV when Brenda.
It's
You
almost
know,
quicker.
we give it
Yeah.
subcut, but if it's IV.
IV
boy,
works,
a lot
it
more
works
like-
really well.
Oh, do they? Oh,
It works
no.
really quick.
Oh,
Yeah.
yeah.
Yeah. It's just constantly going in all the time, and so you're not waiting for a injection to start to work, it's just constant, like, going in all the time.
But equally well, if you're giving IV glucose.
Yeah.
The reduction in blood sugar once that is peaked is much quicker than when you raise the blood sugar by diet. You push the blood sugar up through food,
Yeah.
it stays up longer. So if you're doing it IV, you say, oh, well, it's not much of a problem, it'll go up, it'll come down quickly. So they haven't got a simple answer. It is more complicated. I think you agree with that. Yeah, it's what the body wants. The glucose is the chemical that the body is looking for. Whereas if you put in sugars from fruit, etc., the body's got to break those down first into glucose, and then you'll carry on producing. Your initial dose of IV goes and down. With fresh fruit, it's going to stay up longer. So it's a different issue there.
Although it's IV, it's just, you can just give a small
It-
amount.
it's-
It's IV.
it's a little bit-
2 units.
Yeah.
Four.
So, and you monitor it closely.
Which every hour.
I don't want people to think, oh, it's easier if it's IV.
Just say that the dexamethasone saved loads of lives, didn't it? It was just for like our lot, it was a real problem.
It's still safe.
Yeah.
It was just another complication with the blood sugars.
Yeah.
So it did still work. We just had to, it's like if somebody's not eating and drinking in hospital, giving them feeds or nutritional supplements, the blood sugars go up, but we just manage that high blood sugar because we know they need the supplements and they need a bit of time. So we just have to manage the blood sugars whilst they're in. Okay.
From the chat, I've got a question. Are type 1 and type 2 managed differently for surgery?
Only in respects to background insulin, isn't it really? So as somebody with type 1 diabetes, the background insulin is continued at the normal dose. For somebody with type 2 diabetes, it's a 50% reduction in the background insulin if you're on a background.
How does that work? Do you supplement it with fast acting then?
We
Oh, was it-
use the intravenous insulin infusion as well, so we have the background insulin and then the intravenous insulin infusion.
Yeah.
The reason we leave the background insulin running is that if that intravenous insulin gets interrupted for whatever reason, somebody disconnects it while they go to the toilet, or they have a shower, or they go for a cigarette, come back, they've not got any background insulin, because IV insulin only stays in the body for a few minutes, so they wouldn't have any insulin. So we always leave that background insulin running now to reduce the risk of acidosis.
Yeah.
If you're on tablets and not insulin, how does that, work?
You wouldn't have your tablets if you're on intravenous insulin. You don't have your tablets.
So in other words,
Intravenous
the
insulin.
day of the operation, it would be, I know I've been told not to take things, but
Yeah.
you're saying it's going to be insulin through the day.
If it depends how long your surgery is and how long it is. So if your surgery is say half an hour and you're going to be eating by lunchtime, we would probably do what with that fasting shake where we would just monitor the blood sugars. And it might be that they start off at 6 and stay at 7, 8, 9. If they go above 12 for 2 readings, that's when they start the intravenous insulin. If your surgery is going to last for 4 hours and you're not going to be eating for 2 days, then we will need an intravenous insulin infusion.
Nice.
like I said, once you've had your surgeries, once you're eating and drinking, you're given your usual insulin dose. That may need adjusting if you're not eating as much as normal, if you've had part of your stomach removed, or you're just feeling very sick with the anaesthetic. We're not wanting you to have your normal dose of insulin, so it may well need reducing. And then we'll stop that intravenous insulin as soon as we can. We don't leave them running any longer than what we need to. And so as soon as you're eating and drinking, we'll get that down. Your appetite, like I say, as your appetite improves and your activity improves post-surgery, your insulin doses are going to need adjusted again. Old medication, maybe that, you know, you've been laid on bed for a couple of days after your surgery, and then suddenly physio comes and starts making you walk up and downstairs or up and down the ward and things. We do need to try and adjust things. If you're lucky enough to get a post-op urinary infection, that can push your blood sugars up. So we just want to try and get your control as much as possible in the post-operative period. I think that's on the nutshell. So is there any more questions on sort of the pre-op side of things when people coming in for surgery?
I had to go in about 10 years ago for surgery, and I was like really scared. I just thought, oh, no one on the ward will understand diabetes, and the nurse who was like my nurse, her daughter was about 14 and had type 1. She was like, oh, such a weight off my shoulders. Dead.
So I'm Cheryl. I'm the inpatient work with Clare, but she's moved on now. So I think we spoke about this earlier. Probably, do you have any fears or worried about coming into hospital? The things that went well, things that could have gone bad. We've covered it, but you wanted to mention anything now? Covered it? Yeah.
What can patients do to make sure that we can do get the best to help with those diagnoses?
I think it's a dream when everybody just knows, because you're right, and through no fault of, I used to work in the busy orthopedic ward. I didn't know, since I have no clue at all, not because I didn't want to, but it's so and I was dealing with orthopedics, broken legs and hips, and that was my speciality, and that is what I focused on. What we're trying to say now is that 1 in 5 patients go to hospital with diabetes, and although you are dealing with a speciality, orthopedics, hematology, anything, that a lot of your patients will have diabetes, it will prolong the stay. So listen to the people that can manage it themselves. I would say, kind of be your own advocate if you can as well. So I don't think that's right. Can I just ask you why I'm doing that? Am I right to give my own insulin because I am capable to do that? So questioning as well what people are doing, not because they don't know. They often appreciate it. You know, don't take my insulin off me. I know what I'm doing. If you don't, we ask them to assess you on every 24 hours to make sure that we can give you your own insulin. Because things do change in hospital. People do get confused with disorientated, even just because of the environment. So they do a session every day to manage it yourself, to not be patronising, but just to, you know, ask questions who think something's not right, or
I think we've got the fear of being seen as a difficult patient, and that's really, I think that's a concern that probably most people have.
It is, and with the respect, it is quite difficult to manage and complicated, and because there are so many insulins and so many different treatments, and still more coming on the CGM, you have to be a specialist and expert like you guys are in diabetes to be able to manage it, and the nurses on the wards and the doctors are not, because they're not dealing with it. So we try, we're having a big education program starting soon. We're trying to be on the wards, be a bit more visible, speaking to the nurses, looking at any incidents that have happened and how can we make it better. So we're constantly trying to educate staff and make things better. That like, you know, the turnover, the staff retention is really poor at the minute. So we do try, and it is scary that they do refer a lot more now. A lot more than they did. So they're reassured that somebody at some point can see you and know that I'm not saying everybody on the ward doesn't, and that it is very good, but yeah, we're around, there's 11 of us. So
Yeah. I didn't mean that we're like complicated medically. What I meant was we might be seen as stroppy. I think sometimes you feel like you're fighting for your life.
you know, well, condition.
I think there's some appreciate
Yeah.
she's saying, let me do it myself because I know what I'm doing.
Yeah,
Because
yeah.
it actually, if you're saying, so before you eat your meal, and you're able to do it, it frees them up to be doing somebody that can't
Yeah.
have insulin. So I think if you are able to self-manage, and you know, most nurses would actually say it's fine as long as they've assessed you and safe, because I think there are the patients that sometimes you know that actually what they're doing is not safe,
Yeah.
and
Yeah.
they've got to say, you know, yourself and
Yes.
Yes, I'd like to support what you're saying. An awkward patient.
Awkward, yeah, that's.
I had a cataract operation done 3 years ago, and they've now got a conveyor belt. You don't know which bit of the machine is coming down to see you at that particular time as you go onto this. So pre-op, I said to the person who was taking my history, I said, well, who's the consultant looking after me? He looked at me. He said, why do you want to know? I don't think he knew that I was a retired officer. But I thought that really highlighted what you just said. There is still a great, sorry, if I go on, tell me to shut up. I did my homework before I came.
It's interesting.
There's still a tremendous feeling of them and us. That hit me when I was going to be admitted to the Elective Hospital for knee surgery donkeys years ago, 1980 or something like that. And I had to sit on one side of the table and a clerk sat on the other side of the table. From that day on, there was no table in the middle of my outpatients clinic. They were always on the patient and doctor. Eventually, the hospital design, it was redesigned like that. So, but that's still there. It's our job to do yours. Just get on with it. I don't know who the surgeon was who did the operation, but he made a big mistake. He argued with his sister. I know who was right. Sadly, I know who won.
Yeah.
But in fact, it was okay on the end. So there is a tremendous divide between them and us. And I feel I can stand on both sides, but I've seen that. You as we as the patients own our conditions. They don't. So if they are reluctant to tell you, I think you could very reasonably say, but it's my condition, not yours. You've got to let me know what you're doing about it. Now, it might take an awful lot of nerve to do that. And you might have to find a tactful way of doing it. But when my wife was in the hospital, you can quote me, I don't mind. They're nice. Hierarchy. They know a little bit about my connected past. But Mary was in with pneumonia, and she was prescribed X number of units of insulin. She said, "That's too much. I'll go hypo." She said, "It's prescribed. You've got to have it." She said, "I'll go hypo." Fortunately, she knew how to get out of a hypo. That was because it was them and us. And at the same, shortly after that, I was in there, and you mentioned it just now. I said to one of the staff nurses, "That person's afraid of diabetes." And Mary just said, "Exactly." Because of course, Mary had something to do with your unit a while ago.
Yes.
when it was 2.
Yeah.
Big people are frightened of
And
diabetes.
they are depriving.
Yeah.
I think it's very difficult. And we as us have to remember that these people are looking after only 1 in 5 of people with diabetes. So 4 out of 5 people haven't got it. So the majority of the people they're looking after is not an issue. And so chances are then it's only going to breeze by them. So I think we have to understand why the hospitals have a difficulty. But I think we have to work out a way of getting through that cloud, that curtain between the two. I regret to say, I think them and us is going to get worse and worse because of the increased amount of sessional work. So he's finished. No, he's got to go. Somebody in surgery as an assistant who says at 5 o'clock, I'm going now, somebody else is coming in halfway through the operation. And that commonly happens. And the anaesthetist will swap over because of that. And that's going to get worse. And I think that patient groups will need to watch this and hopefully come to bear influence on them.
Yeah.
I'm now referring to us as the patients, and they become them.
Yeah. We've had some really lovely hospital and community health staff speak to us who are really, they've just been so lovely, and I think we build on them, don't we?
Yeah.
So
I can say, you were saying about 4 out of 5 haven't got diabetes. Just as a matter of interest, when people come into hospital, are they always given a test for diabetes?
Yeah. So,
Unfortunately,
not.
doing a lot. Response, not only from the field well hospital. Feeding the regime, during G20 or steroids, IV feeding can have as well if you're given any kind of pancreatitis. So there's lots of reasons as to why we check somebody's blood sugar that hasn't actually got diabetes.
But wouldn't it be a good idea, because you were saying that in COVID, lots of people had already got diabetes and didn't know it, wouldn't it? I mean, what effects would that have had?
Probably down to costs and things.
Yeah.
I mean, I would say most patients do probably get urinalysis done at some point during their admission, but it's not routine that they get blood sugar checked or the glucose checks on admission. It's not routine.
Sorry, I've got to say, I did cardiology pre-admission at the Northern. We used to do blood sugar every time as a regular. That was a number of years ago.
Yeah.
So things might have changed.
Certain areas do. I used to work in critical care and we did, but that was because they were really sick and we needed to keep them control with the stress response. So
Yeah.
if only.
So,
And we did touch on some of the earlier on, so self-management, if you are able to self-manage, so they self-manage and self-administer, with two very different things. So if you have type 1 diabetes, you can carb count, you're DAFNI trained, and you adjust your insulin correct, and you're absolutely fine to do that. They will let you carry on doing that in hospital. Like I say, they will assess you every day. So if one day you don't know, something happens in such as accident in 24 hours in hospital, they will assess you and refer to us as living concerns. Self-administer means you can give your own insulin, you don't change your dose or anything. Diabetes medications equipment, how to get it equipment. Patients come into hospital on different kinds of meters, and Sheffield just have couples. Levers and things, we're getting a lot more of that coming into hospital. We will change them if it's necessary, but we ask you to bring spares, you not ask them to bring you one in if it's comes to its time. Like I say, the hospital can't put the legal blood glucose levels on the spare system. It's not a recognised way system of blood sugar, so we do have to do it in hospital. We do have to do it with a blood glucose meter. Meal times and food. Meal times are very different, like you said. Somebody check your blood sugar at 10 a.m. We ask them not to do that. We're trying to change culture at the minute because sometimes they'll say a fasting blood sugar is 7:30, 8 o'clock, and when we just start to have a breakfast. Oh no, they do the blood sugar at 5 a.m. and call that pre breakfast with gluten. So we're trying to make sure that they're doing it before breakfast now, not 3 hours before you have your breakfast.
And is this just done before the op?
Just whilst you're in hospital. This is anybody who come in hospital.
But when you're in hospital, after the op, I mean, I don't know how many days I was in after the op, but the consists with blood. They didn't say don't eat until we've had taken your blood glucose.
Yeah.
So, I mean, I didn't, but I could have had sweets and whatever. I don't think I did. Yeah.
Too late now.
So pre and post meal reading. So we say that they do it pre-breakfast, pre-lunch, pre-meal, and pre-bed. Sometimes we can see when they've done it post-meal, and our phone will say, was that after lunch? Yeah, it was just a normal one. So we can kind of see the pattern. But yeah, we ask them to do pre-breakfast, pre-lunch, pre-meal, and pre-bed, and that will be done for 48 hours. So once if you trigger and you refer to us, we can say reduce it or increase it. You should always clean your finger as well. Do the blood sugar.
When I was in a couple of years ago, I had a great deal of difficulty persuading him to do the pre-bed one, sort of, around about 10 o'clock or 11 o'clock, or even midnight. They wanted to do that sort of, well, I'd call it evening meal more time. Because I wanted to be sure I was going to be safe overnight.
And you can challenge that, like we've just said. You are an expert in. Say, I'd rather not do it. Just do it a bit later. And you can challenge that and give them reasons as to why you challenge it in a nice way.
You're saying about they can't fix the lever sensors. If you're having an op, I mean, how does it work? I mean, does it work with MRI tests? You can't have an MRI test if you've got one. What about ops? Can you leave them on if you're having an op?
You can leave them on once.
It depends. Some of them, it's the pumps have to be removed sometimes if they have
But these can stay on. So it's as well to take a spare. If you're in hospital, get somebody to take you one in. Just hand it.
Yeah.
sometimes.
It has to be removed.
Yeah.
I've got a food question from the chat, which is about people who have a low carb diet as part of their diabetes control, and how is that reflected in their food choices that is available to them?
Because people are unwell, it doesn't always apply in hospital, but granted, some people might want to continue that if they're well enough to come to hospital. We do have a carbohydrate, we have a menu with all the carbohydrate content of all of our foods, which is quite a recent addition actually. So if you have type 1 diabetes and your carb count, we'll give you a menu and it tells you how many carbs are in each of the meals, and you can choose accordingly. But in hospital, if you're unwell, we say just to within limit, eat what you want, what you fancy. Even if you've got diabetes, you don't eat anything all day. You feel rubbish. You want a pudding or whatever, we say just eat what you want and we'll just manage it to say
That's interesting, because I had an occasion when I got told, well, you're not having, you're just having just a smidget or something.
Oh.
Yeah.
Yeah. We used to have diabetic jam and all that kind of stuff. That's I mean, we don't say fruit juice. I had a guy a while ago give me a fruit juice every morning, and they wondered why his blood sugars were ridiculously high pre-lunch. I'm like, we're giving fruit juice every morning. You can have a bit, maybe dilute it with water, so that his blood sugar was having this fruit juice with an alternative. So yeah, that challenge it.
Because you've not got, if you are in, and you've not got that kind of last order and you've listed.
I don't ever remember seeing a menu. Is it, well, the last couple of years it's coming on?
This year, yeah.
Right, that's what
It's
it's on.
updated. We talk all time, do you?
Yeah, there's winter, autumn, winter, and spring, summer.
Thank you.
Sandra's online, she could comment on this.
Conscious of time.
Yeah, so
So insulin medication, the timings and drug rounds doesn't always fit. So we're trying to change again the culture of the nurses tend to do the tablets first and then give the insulin afterwards, which often insulin can be given at 10, 11 o'clock. So we're trying to say, give your insulin before you give your tablets, give it before patients have food. Like if you're self-managing, self-administering, you know, that's a bit easier. But it can be very difficult when they have 3 days of patients as well. So just bear in mind. So we are trying to change things a little bit. Hypos, hyperglycemia, we have a criteria. 4 is the floor in Sheffield Teaching Hospitals. If your blood sugar drops below 4, the patient's a little bit different when they're at home. We class that as hyperglycemia, and that would have to treat it according to our policy in hospital. If you're above 17 on 2 consecutive occasions, then potentially we'll give you some quick acting insulin to try and bring your glucose levels down. That's the knowledge of staff on ward, like I said it is. So we all thought of it. It's not diabetes. We're trying to get it better, but it's not. But it's mine. But you know, nurses are fantastic. They've run a lot of pressure at the moment, but we're there to help, and they do ask us a lot. Yeah, we're really busy. So and they do refer it's just goodness and rest assured.
you know, she would say you'd been in a bike accident or something. Would I suppose it would depend how badly injured you were, or is it, I suppose the patient's welfare comes first, doesn't it? And that's what, so you might take over because, well, if the person's not able, then you would. Yeah,
that happens a lot with stroke. So we have a lot of patients on type 1 that have a stroke, and we do so we try and keep it as similar as we used to keep the background. And then if they're doing blood sugars pre-meal, pre-bed, we might say give them this much of the blood sugars this, or give them this much of this, depending on the patient. Yeah, strokes example. Or we put them on a variable outside instead.
Shirley's got something on food from the chat, which says you do get a menu to choose from, and they are introducing electronic menus. She's recently done ward assessments, which included sampling the food, and they do have a choice. There is a choice.
They're all
Right. Right.
And reasons why diabetes may change in hospital with a few illness, infection, like I said earlier, the stress response, COVID posed a lot of problems. Changes in your kidney function, so you come into hospital, kidneys and the way that they work, so some medications they have to be stopped, some reduced, it makes it a lot longer. Medication get out of your system, which can cause more hypos or dietary changes, meal timing, missed meals, not actually wanting to eat at all. Some of the stuff looks really good now, but some of it not so good, not some days you get. And not access to your own fridge. So at home you can nip in and out of the kitchen, get yourself whatever you need. Yeah, 7 o'clock snack for me with a cup of tea. You can't do that in hospital. So your blood sugars may grow lower for that reason. We call it no access to fridge. So we did have a guy once that was in the kitchen helping food snacks, but yeah. Oh, we moved on. No. reduced activity, like I say, you had a, did you say your knee or broke your leg? You're not moving about as much, obviously movement helps you burn more glucose, sugar. Possible increased activity, doing physio and OT. We do some sessions with the physio and OTs every 6 months, and we do say to be mindful of hypos. If you're getting somebody up out of bed and they do have diabetes, that, you know, if you're not doing any exercise for a while, it will make the sugars go low. We've had a couple of instances where people have had physio, they have had hypos like that in physio. Possibly medications that affect the glucose levels, such as steroids, feeding really, like I said, feeds like TPN and things like that. Medications may change with start depending on certain blood results, like I said earlier, some of the kidney function thing. Metformin is often stopped in hospital if you're not eating, drinking much, or the kidney function. Meal by mouth for procedures, we spoke a lot about that with Clare. Demands on ward staff, workload, insufficient staff and level, may affect instead of administration time, like we said earlier. It shouldn't be an excuse, but you kind of have to take it into account. It shouldn't be an excuse.
Does antibiotics have any different effects on people who've got that high blood glucose? And the other way around, does high blood glucose have any effects on how effective antibiotics are?
It's generally the infection that causes the high blood sugar.
Not the antibiotics. Okay.
What's TPN? You said
Total parenteral nutrition. So it's like feeding for somebody that can't have a feed, and they've got some stability issues, so they give it out through like control. Inpatient diabetes service, so they was Clare, me, 10 of us, soon to be 8. There's a couple of people moving on. There is a referral criteria that the wards adhere to, so depending that you have to meet that criteria to be referred. I will say that we just refer everybody, which is a good thing for you guys, really. If admitted with diabetes, we should be seen within 24 hours. So it's an electronic system. They will refer on us. We'll pick it up within half an hour, sometimes even less. And we will prioritise it, triage it, and then we'll see it within 24 hours. Diabetes guidelines, so there are guidelines on high flow, hyperglycemia, DKA, VRIII, sliding scale, and HHS, which is another complication. There are all guidelines for all of those.
what's HHS mean? What's it stand for?
Hyperosmolia, hyperglycemic state.
Is it like DKA but more type 2?
Without the ketone. Generally type 2, severely dehydrated. So it's about the shifts. You tend to be really, really dehydrated, and you have a really high blood sugar up to 80. I've seen it on the web. It tends to be you replace the fluid first rather than giving it fluid.
Because there's not enough liquid around.
Like severely dehydrated, shriveled through.
That sounds so awful.
Does that mean that drinking water could bring a high blood glucose down because you're hydrated without realising?
This is in some acutely unwell with type 2 diabetes. You usually see it in type 2 diabetes, so it's not just that drinking liquor bit, it's really dehydrated, with severely dehydrated and often need sort of liters of fluid to get them rehydrated.
We'd monitor for glucose more regularly, like I said earlier, when you first come into hospital, so we have an understanding of the trends, so we can see what's going on. Like I say, your blood sugars at home might be actually, you come into hospital, the ground fifth hits the bar, and that's it. It's in the doors. It's like, it's not nowhere. So everybody, the patient, quiet. Everything was in target. That never patients are in hospital earlier. It is a moment. We have a super alert, so this is what we call active case. So we have an alert every day that tells us who's in hospital, and we can search the hypos and the hypos. So if they haven't referred, we can check the other room. And if it has any below 3, we'll review them. Any above 27.8, we'll review those as well.
How do you find that out?
If we get it on our computer,
What from the figure of the nurse?
on your admission, so everybody that comes into hospital, put on a system, it comes from this system.
And is that from like leader of you, or is it from?
No, it's the hospital.
It's the hospital, yeah. It's an electronic system. It's actually good information for the patient. So exactly the people with diabetes is taken
Not
from the
done
retinal
themselves.
screening. So everybody that's on the retinal screening program is listed in the hospital or in the database. If
Yeah.
they're admitted with blood sugar, and it will match the blood sugar to that patient, and we get an alert through that says there's 65 patients in hospital today with diabetes that have been admitted in the last 24 hours. We can pick down what the blood sugars are and things on them.
Is that as one off blood glucose when they come
It's
in?
one that you do on the fingerprint.
Yes,
So
it's not.
it will be in a
sign.
no, it will be all through the day. So if you've been in for 5 days
Yeah.
and they suddenly have a 2.3, that would come through on the next morning to say that they've had a severe hypo and need surgical manual.
And we prioritise the hypos as well, so the hypos will see really quite quickly. And discharge planning, referral back to your own team. I think you had a couple of questions on discharge.
Yeah.
We try our best. Discharging certain patients with diabetes can be really complicated, so we always say to the nurses, can you think about discharge as soon as these patients that have district nurses at home, or we've changed their regimes, but we do try and refer you back to wherever you came from. So rather than have a lot of out of area patient, Barnes, right? If you've seen a community nurse recently or an outpatient nurse, we wouldn't automatically, if everything's been all right, refer you back. We might let them know if you've been a bit of them, but they have a backlog as well, so you wouldn't necessarily see somebody straight away. We do have a post-discharge follow-up clinic, so if you've been worried about your hospital and we think you might need a little bit of extra, we'll arrange a phone call within a week when you discharge, and we'll phone you up and just see how you get on. There's anything you need us to do while you've been at clinic.
I've got some written down ones.
Who's asking?
There's a blood clots and prevention and whatever.
Yeah.
When you're in and coming out. Yeah, any sort of comments on those?
I do with diabetes, but from past experience working on the ward, depending on how long you're in for, what surgery you're having, how mobile you are, they put your stockings on and you have prophylactic injections for thinning your blood whilst you're in hospital every day. Yeah. Depending on what you're in for, how long you're in for. And the dose depends on certain things as well.
Yeah, fine.
And an experience I had in hospital, halfway through the main meal of the day, a nurse with blood pressure monitor testing me here and then testing my blood sugar halfway through the meal.
Yeah,
Just unfortunately.
And I've had a kidney transplant. I now need twice as much insulin to what I used to since then. I don't know whether that's a bit slow. There's steroids and there's medication for the thing. But it was also suggested that because of poor kidney function, I wasn't peeing out the insulin I was taking. So once I was peeing it out properly, I needed more.
so if your kidneys aren't working for you,
It was staying in the system.
once your kidneys are working, it kicks it out a lot.
Okay. So one question is, what happens now when a patient is discharged on steroids? Our GP surgery is given instruction on how to support patients. And then the one that you've got written down is.
All right, so that was a potential problem arose re hand surgery and living alone. The comment here is that they found that the district nurses would not administer insulin on the patient's say so when Daphne they had to work to a prescribed dose and did not make adjustments. So it's that,
Yeah.
it's that application, advocate, and then
I would argue, and nurses will do now, that if somebody's having a hypo, you're not wanting to give the next full dose of insulin. But they could say, we've just given you reduced dose and you get it reviewed later. But for a district nurse, they've got strict, that they can't adjust it. Even if as a diabetes nurse, we could recommend they can only follow what we recommended. They can't give a different dose of insulin. Right.
It's
They,
really,
throughout, they will ring us sometimes and say, oh, actually, with this patient, and this is their blood sugar. Do you think we need to be giving a different dose? And we can give them advice then to give a different dose. But technically, if it's prescribed that level, they shouldn't be able to give a different dose. It's a difficult one because with diabetes knowledge, you know, actually, we shouldn't be doing that.
Yeah.
But it's a hard response.
If it was one hand, she could have said, could you give it?
Yeah.
Maybe.
I having two at once, it makes you like in quite a difficult situation for all parts of your life, doesn't it? You know, clean your teeth, brushing your hair, and the other things. But I think
it should have happened to me, but I changed my mind very last minute about the hand surgery. And the problem was that I had to know when I was going into hospital for a hand operation, which meant it would have been difficult to do blood glucose checks before I'd got a monitor, and also injecting yourself with one hand would be difficult. So the diabetes team said I had to make out a menu for a whole week and put down my doses at the side of what I was going to be eating, so that the district nurse could then give that exact amount, because they said that they wouldn't work to a patient being diapneid, and or if you had made out a menu and then all of a sudden that day they didn't, you did change your mind and you weren't going to eat that because you didn't feel like it, or you couldn't get hold of the things that you said that you were going to eat. And it just posed a problem in that there was no sort of, the patient, I couldn't say to the district nurse, I require 10 units of quick acting insulin. It had to be already organised, presumably because maybe mistakes had happened in the past and district nurses had given some insulin to somebody and it was the wrong dose or whatever it was. But obviously they did find a problem with that.
It's difficult, and I think what you could argue that your complementers, you know exactly what you're doing. You've only hurt your hand, you've only had an operation on your hand, you know, I'm telling you this is what I would do. But it's a sticky wicket really, because it's part of their body, and it's very difficult. It looks, if anything was to come of that, we would look like we've given a dose that we potentially shouldn't have given. So it's
Just say that last bit again, please. I do have a problem with hearing.
Oh, it's all right. If a problem would come of that, if we'd given you a dose and you'd say, give me this, and then, I don't know, something had happened, it would be the nurse that would get into trouble for giving you that higher dose because she'd administered it. So it's tricky, it's really tricky, but frustrating for you guys, I think.
Yeah, because if your blood glucose was high, you would need to do some corrective.
Yeah.
And that's where it all fell down.
it's interesting. But I suppose insulin's lethal, and we're all really confident about it, but it can be lethal.
Yes,
Yeah,
of course.
yeah.
We're needing different amounts at different times,
All
different
with similar
days,
names,
so that
yeah.
there isn't what a pattern to be prescribed, isn't it? So that there's no easy answer to that.
It is really difficult, and I get it's totally frustrating. I guess, like with Cheryl saying, it's also a nurse got to protect herself, and also if she has got somebody that, you know, they go see some of the patients and actually I want 35 units of quick acting insulin, and they give it without thinking, oh, that's a bit of a strange dose, so that's what they
Yeah.
I should say that patient's confused, but they not pick that, because some patients, you know, are very good at actually telling you that this is exactly what they normally do, and actually they do question it further back.
Yeah.
So they have essentially, I think, got to protect registration as well. And it's difficult. It is a hard one. It's
I wonder whether, I just wonder with, because when I had hand surgery, somehow I managed during the day, I think because the finger still worked and the other hand was okay. But I wonder whether people could see an OT before the surgery to work out a way of doing it themselves.
If you use like flex pen, that's got a really long reach and it's really hard to push down. You switch that to the quick pay, it's got a much smaller reach and it's a lot easier to press down. So there's ways and means of that.
That's interesting, yeah.
So sometimes you look at the devices enough to actually just help out enough, or if they could, you know, you could get a relative to pre-diary dose. So they could pre-dial us, and literally then all you've got to do is inject it rather than, you know, you've got to dial it up as well. I've had a patient recently, actually through a pre-op clinic, who's got multiple sclerosis, but she was actually changing her pen needles with her teeth.
Oh,
And she couldn't manage any other way and hadn't been picked up. But that's how she did it. She managed to dial the dose up, but actually, you know, to think that somebody in this day and age with carers going in was actually changing pen needles with the teeth was just quite a belief to me.
Yeah.
We've got on safety needles, and she used to get the carers sometimes to change it, but again, risk of needle sticking into them. So now we've got on safety needles, and she's managing really, really well. They've got the lead for her, so she's, you know, her life sort of turned around quite a bit, but it is difficult. But there are ways and means around thinking actually with a safety needle, a different pen device just might help for those few weeks while you had your surgery.
Yeah, even picking the needles might be difficult.
But things like, I mean, just stopping that shit on how important, but the mobile's great because you don't have to have a separate screen. If you've just got your, you know, if you've got one hand, you can manage to get it on, so you can press the button with one hand.
Yeah.
You can actually get the blood onto it. It's just sometimes thinking through a little bit about the devices that you're using, the samples, whatever, as well.
The steroid question. I don't want to miss that one because I do a lot of steroids. It's my middle name. I think they asked about
I can read it out.
GP managing. Lots of patients are put on steroid in hospital and then taken off them. So when that put you on treatment while you're in hospital that you might not need once the steroids have stopped. We are trying to get out to the GPs to highlight this. We're working a lot with Western Park Haematology at the moment, but it's going to take a bit of catching up. So if you're on insulin, we tend to follow you up for a bit and try to communicate. If it's just tablets, we tend to send you off back to your GP. And we do write on discharge letters, so we do know that we have to follow patients up, but it's taken a while to get this fairly new information.
Yeah. You know, if you're on steroids, should we just use sick day rules? Because they're just dangerous, I think, steroids.
Sometimes you need to up it massively.
Yeah, shockingly large amount,
Some patients are on mixers. So mixed insulin in the morning and in the evening, which is a mixture of quick acting and a longer acting insulin. So it's a bit tricky to manage. Like if you have type 1, you're used to managing sick day rules. Patients on mixed insulin, it's a bit more tricky.
Imagine.
Patients, what do the inpatient nurses do? So there's 1 in 5 patients in hospital anytime with diabetes, whether that be 1 or 2. Not able to see everybody during admission before. Referred to electronically and triage via DSN. May or may not require a face-to-face visit. So just to say, if you are in hospital, we might not always come to see you face-to-face. If it's just about upping or downing your insulin, we tend to do that remotely. We have a lot of referrals in a day, so it's impossible to see everybody face to face and often a little bit inefficient. So if you definitely need a face-to-face education, you've asked us to come and see you for an appropriate reason, you've had a high flow, you need some education, will come and see them face to face. If it's just about putting or down it, we give the doctors on the wards advice on what to do and a bit of a guide for 7 days to follow. They'll follow that for 7 days. If the problem's not gone, they'll bring it to us. Insulin or medication. Tricia mentioned it, so we will up or down insulin whilst you're in hospital. If you've had a change of regime, if you're new to insulin, we've totally changed it completely whilst you're in hospital. Because often patients coming on regimes they've been on for a long time, and actually when they come to hospital, it highlights it's not working. So it might totally change things. So liaison with that. So that is face to face with it. Diabetes emergencies, it shouldn't happen. It sometimes does. Patients shouldn't go into DKA, diabetic ketoacidosis, while they're in hospital. We shouldn't really have severe hypos, but it does happen for multiple reasons. That we try and avoid them and we prioritise them, see them as urgent. Patient education, like I say, different insulin regime, monitoring. We're trying to get, not everybody that has type 1 diabetes has a lever on at the minute, so if we come into hospital with catch them with proper lever on them. Discharge planning, we try and do that at the beginning. So you're laughing.
Oh, just you harness Libra. It's like brand them with a Libra. Slap them on the shoulder.
Yeah. Which is fair deal, isn't it?
Just thinking with the lever with the alarm on, do the other patients complain?
Yeah. Yeah.
Music is also.
We've got a meter in our facility and it keeps going up. I'm like, where's that? And we're all searching, how did he go for it? New diagnosis type 1, obviously we see discharge planning, like I say, we try and do that sooner rather than later. And staff education, both formal and informal. So we're trying to restart our big diabetes 3 days for staff. So we do a lot of stuff with the doctors, a lot of stuff at the minute. A lot of quite reactive teaching. So if there's been a lot of incidents, we'll look where the incidents are. Focus on those wards. We each have clustered areas, so each directorate within the hospital we have a DSM to cover that directorate, and they focus their attention on the directorate. And this is our referral criteria, really, but quite boring for you guys, really. But the red is a definite, so all the reasons why they should refer to us, hence why we get so many. Insulin pumps, anybody with type 1, anybody with an acute foot problem, on feeding regimes, blood sugars above 12/48 hours, above 17 on 2 occasions, sugar above 27.8. So it said above 27.8 because that's the only, our hospital meters only go up to 27.8. So at that point, at that point, we asked them to do a lab because it could be a lot higher. Any hypos, DKA, pregnancy, emergent referral, steroid therapy, patient request. I mean, yeah, absolutely, definitely. The guy that wanted to know why his foot were itching a few weeks ago, I don't know. So there are things that we don't come and see you for, but if it's a legitimate reason and you need some advice whilst doing it, sometimes it's time to actually have a conversation. Renal transplant, always, yeah, priority. And that's how the nurses return. So
Can we share the slides after the yeah.
Self-administration policy. We do have a policy. It's done. It's ready to go. Just having problem with printing. It's always computer, isn't it? So we have patients. We give them. If you carb count and things, we'll give you like a sheet to write your blood sugars on, how many carbs that you've had, how much insulin you've given, and just let you get on with it. And the nurses follow a guideline. The nurses follow a guideline whilst you're at hospital to enable you to salvage. So we ask the nurses to do it every 24 hours, like say something can be coming well. feel sick, nausea, you don't really want to do it yourselves. Check regularly. Show safe storage of insulin, take people off every time, yeah, so if you can, and you take your time. You should have sharp bin at the side of you, which they will provide. Don't leave it on for us. Take off, we tell them not to. Carb menus we've already spoken about. Even if self-managing, the blood glucose needs to be checked on the meter, which we spoke about twice in 24 hours. Maybe a discrepancy in reading, this is massive. So if you do a blood sugar on your meter and we do one in the hospital, there could be a big difference. We have to go on the hospital meter. Just because the calibrator really regularly, and it's just something we just have to do that. So, the diabetes medication in hospital, like I said earlier, equipment such as reusable pens, CGM, flash devices, pump should be brought up. Device should be removed when attending certain scans. So MRI, they're really precious, which they definitely should be. It's really expensive, but everything comes off. If less than an hour, insulin pumps can be removed. If more, then alternatives will be considered. So, like sometimes if you go to a shower, it stresses the nurses out, actually take my pump on. But yeah, if you're just dipping for the shower, you can take one off as long as you're self-managing. But if you, like I say, can't manage them, then different regime. We'll automatically replace Libra, Dex control one for the stairs. Yeah, we don't. We have kind of just have a replacement. The few and far between run out really regularly. So if you can bring your own and get somebody to bring them, we don't say that cool, but it's best if you bring your own stuff. Libras of self-managing diabetes team you. So the readings that you get on your Libra whilst you're in hospital continue to scan all day long. The hospital, we don't expect the nurses to react on them results. It's for us as a diabetes team and for you guys whilst you're in hospital, not for anyone else. Pumps can and should be left replaced. When able to manage a pump, you should remove it and prescribe alternative regimes. Pumps will then be labelled and kept in a safe place due to the cost of it. It's cost about £4,500. So we do say that we put in a locked container labelled similar to one, so it's a fluid unit, so it costs a lot of money. Make sure they're available and shipped.
I've got a question here. Do patients have to be woken in the middle of the night to check their blood glucose?
They shouldn't. Unless
Should if sometimes if things look if we're struggling to manage, sometimes we may ask not for we don't do it. Patients are tired of it. If they've hypoed or they've had regular hypo stats. So sometimes we don't ask routine.
So could we request not to be woken in the night?
Unless you look hypo, then yeah, you can request that.
Oh, good, thanks.
Follow-up is arranged to appropriate teams, whether back to GP or then if necessary, the post-discharge clinic, like I mentioned earlier. Titration plans up or down on your insulin, deals with providers on an individual basis. So we have plans for patients to go home with. So if your blood sugars have been up and down in hospital and you're on like a mixed insulin, we could give you a plan to go home with, which says when you go out of hospital, your blood sugars still might be a little bit high. So follow this plan and we'll phone you next week. May need to think about adjusting doses post-discharge as appetite and activity improves. So you don't eat much in hospital, like I said, no, it's fridge, you're feeling rubbish anyway. You go home, you're back in the fridge, you're back watching and slept to get more. Yeah, which happens. That's it. Any question?
What would be the effect if you did test everybody for diabetes? I mean, would it be a time or cost of both? Can't imagine it'd be a cost, would it be more about time and the cost of treatment?
For the secondary, I think probably will be back cost of the blood test, which sounds really silly, but there are issues around costs of doing extra tests, but then the caseload, and I think we would really struggle to manage. It would have to definitely look at, you know, a caseload to manage that. And then, you know, we say we've got 10 staff now, and that's not, they're not all overtime equivalent. So that's, and they do a 7-day service. So I think, you know, that's, you know, 7 days, the only day, I think it's Christmas Day, isn't it? Christmas Day, New Year's Day, that's the 2 days off that we don't cover the rest of the time. So it's on a lot of stuff. If you spend, you know, 7 days, and then there's not many others around here. I think it should be done. And we certainly found that with COVID, didn't we? That a lot of people we picked up, like Cheryl saying with the steroids now, anybody that starts steroids, high dose steroids should have a HbA1c check. So I think we're probably identifying more people now. I think COVID, we picked up a lot of people that have diabetes that didn't really have it.
It might work out cost effective in the long term.
In the longer term, yeah.
That makes sense.
But the other basic blood tests done as a regular basis when you're having to like hemoglobin to that. And then
Something that goes on with it, so they used to do glucose of this. I think recently we should change the glucose on this, so if it's above 11, it actually turns red. So if they do a glucose, it actually tells that it's higher than before it didn't. It was just black things, it just had numbers. So even something as simple as that sometimes it
You were saying you go back to normal when you come out of hospital.
not like
Well, it was more a case of doing nothing, being well controlled in hospital. And then you come out and it's, well, it's nothing like it.
It's not easy, is it? Sometimes our patients don't know, why is everything right? Why is this not working?
I think the flip side to that as well is somebody that's not well controlled, that has like the control of the diabetes, that tells us they're taking 80 units of insulin twice a day. They come into hospital, we give them 80 units of insulin like they tell us they're taking, and they're hypo because they're not taking that insulin. So you're constantly trying to do this bit of detective work and a bit of actually what is really going on. And things are very different in hospital, the whole, you know, and that's why they employ the inpatient diabetes nurses to try and support people while they are in.
Come back to you said they can't, if somebody's got a spare lever, he's got fill out deadline to leave it really. And you say then the nurses, the hospital staff aren't allowed to access.
The diabetes team can, but nobody else can access it.
What would happen then if a patient was allowed to give the hospital permission? Could they look at them then?
I think it would be a training issue for whether the staff would actually be able to.
Because the other thing I was just going to ask, you just mentioned about how much actually they are actually injecting. Would they then be able to, you know, they know this never
The new pen,
where it updates and tells them you're at.
yeah.
I mean, would that be useful to you know how much for you to know how much people have actually been injecting?
It would be useful, and from the diabetes team, I would say, but I don't think the rest of the staff have probably got capacity, but also knowledge to know what it means when they look at that legal data. We actually, a lot of the GP practices are on system 1, but a lot of the staff in the hospital can't even access system 1 to have a look. So I think there's a lot of different systems in place, and it's not ideal, and we are getting a new electronic system, aren't we? But I think for the staff on the ward, I think in their defence, they're doing a lot of other things, and what we want them to do from the diabetes point of view is to let people say that they're not high and not low, and you know, in anything else, you know, you said diabetes is quite complex to manage. It is complex to manage, and I think for the general staff on the ward, like Cheryl said, they're doing orthopedics, or if you put me on a haematology ward, I wouldn't have a clue what I was doing. If you put me in, you know, orthopedics now, I think I would kind of log on and kind of do this. It's just you tend to get into your specialist areas, and I think when you come out with that, so from the diabetes point of view, to keep them safe, and stop them going low, stopping people going out too high, and maybe for the stuff.
We good? 5 to 9.
What?
I think it's been brilliant. Very much.
Yes, yes. Is there any more questions? Oh, Jenny. Got your hand up, Jenny. Are you waving, clapping? All right then, thank you. Oh, sometimes they call it a legacy or a historical one. So
Oh,
yes, thank you, girls, for coming and giving us it was quite enlightening. I've had a couple of day ops, and one that I didn't elect. I was in there as an emergency case. But for me, I'm not on metformin. I'm back as pre-diabetic, so it's quite easy to manage. So yeah. So just good luck to anybody that's having an operation. If you stick to what you're told to do and you stick to what you know, then you should be okay. But the one thing I do say is read those admission forms. Read what it says about if you're having a general anaesthetic as opposed to an epidural, because one you can't eat with and the other one you can. And if you get those two mixed up, you turn up on the morning with the one that you're not having and you've eaten, then you won't be having your op. Because I sat and listened to somebody on the opposite side of a daycare, and she didn't read it, thought she could have something to eat, and she was actually down for a general anaesthetic. So please read those papers very well before you actually check in. So it's 9 o'clock, so have a rest of a good evening, ladies. Hope the weather's improved for your journey home. And
Shirley, can you mention the meetings that we've got coming up and the fabulous raffle where the tickets are only 50p?
Yes, I was just going to say we'll see some of you on Saturday when we're doing about going away on holiday with diabetes. And we have got our Christmas raffle where Lindsay's just said it's 50p a ticket if you want to buy any. You can get them when you check in online for the next meeting. And it's going to be drawn on the 8th of December. So hopefully we'll see you then.
No, that's the camera.
There's a prize.
There's lots of prizes, Lindsay.
It's a big bottle. It's bigger than a few minutes.
Yes, so we will say good night to everyone. Thank you for joining. Thank you those that are online, those that have turned up in person.
Thank you.
Yeah, and see everyone who's coming on Saturday.
Thank you.
Thank you, Shirley.
Bye. Bye.
yes. Thank you. Bye.